right, so troubleshooting for a collapsed tunnel. If you lose your tunnel, the tunnel collapses, you need to have a kind of a troubleshooting list in your mind. Systematically go through, if your tunnel's collapsing, start at the source. Start at the CO2 bottle, check the insufflator, is it on? Is the CO2 tubing hooked up? Is it flowing? Hold it up to your ear. Don't contaminate yourself, but hold it up to your ear. Is it flowing? If it's flowing, is either your BTT port for McKay users, the trocar for the Venapax user, or the scope itself for the VirtuSaft Plus user? Is that open? And then with either the dissector for Terumo or the McKay harvester, if you've moved on to that point, is it clear of any obstruction, either fat or blood? And you can use a syringe, forcefully push a little air through there outside of the patient, because we don't want atmospheric air in that tunnel, just CO2. So take the scope all the way out and troubleshoot it outside the patient. But make sure all of that is clear. If your equipment is fine, then you move on to, okay, is my incision too big? Do I need to add some air to the BTT port for the McKay users? Do I need to put a stitch in for the McKay and the Venapax user to kind of tighten the skin up around the port itself? Have I done an extra stab that I need to close up either with suture or with a hemostat? Have I done my distal stab and grab? If all of that is fine, do you have an occlusive drape over the top of the leg that is constricting everything? And can you cut that and let that fill everything up? And if that is still not an issue, can you increase the CO2? Now notice that is the last thing I mentioned, is increasing the CO2. All of these other things are going to have a bigger impact, I think, than increasing the CO2. Only in rare cases has it ever been a problem that the CO2 at the standard settings wasn't enough to distend the tunnel. But again, you have to respect the CVP, not because I'm worried that you're going to have a CO2 embolism, but because I don't want you to be opening yourself up to the liability of having that. I don't know that it happens as often as we worry that it could happen, but I don't want to find out. So I don't want the patient to be at risk, and I don't want to be personally at risk by cranking my CO2 up to 15 when the CVP is only 8. So avoid that at all costs. Only once in my career of coming up on 14 years of harvesting is a leg that was so large that we did all of these things, and the physical weight of the tissue over the top of the tunnel was compressing everything. And in that case, this is extremely barbaric, but we used penetrating towel clamps, and we just pinched the skin, and we had somebody stand there and hold it up, and then we were able to harvest just fine. Agreed, not maybe the best thing in the world, and shockingly, after the procedure, he complained more about the puncture holes in his legs than he complained about his sternotomy, his incision, his chest tubes, everything else. The two things that bothered him the most were the puncture holes on his thigh, and it looked like a snake bit him in 2 different spots. But that's where I come into my job is to get the highest quality conduit out possible. And if it means that there's a little bit of discomfort because I had to lift that up, then that's okay with me. I would rather do that than make an open incision and have the patient at risk for a wound infection. I would rather have those puncture holes and lift up than get into bleeding trouble and have a retained hematoma that can put you at risk for a wound infection. I mean, all of those things. So it is obviously a risk and benefit. But one time in my career, I've used penetrating towel clamps to pinch the thigh and physically hold it up while somebody harvested inside, just to make room for that CO2.